me share this again too. Yep, pupils are dilated. What about is the mouth dry or is there too much spit? What are we at?
Once you have a drier mucous membranes, decreased bladder function as well.
Right. Decreased saliva, decreased bladder contraction. So, if I look at this list, like this is what I'm left with. I mean, I took it to make it easier to breathe. So that was good. But now I have some issues that I might have to tell the patient about. Who should we be cautious with or who should maybe avoid it?
Wouldn't you want to have caution with diabetics?
Potentially, because the sympathetic nervous system should increase the amount of sugar that's released, so they could develop hyperglycemia.
Wouldn't you also want to be careful with those who have adrenal disorders or issues producing cortisol?
Yes, because especially if they are overproducing or underproducing, I suppose. Um, what else?
People who have renal impairment.
Right, because we're going to decrease blood flow to all those areas.
Liver?
Potentially.
Liver?
Well, if you, what about that heart rate and blood pressure?
Hypertension?
Yeah. Anyone who has issues with like tachyarrhythmia.
Would arrhythmias be an issue too?
Right, exactly. Like just looking at that list, people that might have an issue. We always have to worry about the people with benign prostatic hypertrophy because they're already having issues getting to urinate, and now we've increased their issue with urination potentially. So those are our things to worry about because it could potentially cause hypertension and arrhythmias. We do have to worry about people with coronary artery disease or history of angina. And then we know because of the pupils that we're careful with day driving. And we mentioned education about constipation. So just keeping those things in mind. Now, the antiadrenergic is going to be opposite of the sympathetic nervous system because the sympathetic nervous system is blocked. So it's closer to the parasympathetic nervous system response. Even though it's not acting on the cholinergic receptors, it's not truly the parasympathetic response, but it's a little closer to the parasympathetic response because we are blocking the sympathetic response. So we can expect the opposite of what you guys said above. Is it? I'm so sad. I don't know what's wrong with this microphone.
I think it's whenever you start typing anything that your audio cuts out.
Oh, okay. Well, that makes a little bit more sense. So we'll just anticipate that. So if the patient is having a response that's closer to the parasympathetic nervous system because we're blocking the sympathetic nervous system, then we'll have the opposite of what's listed up there: an increased GI motility, vasodilation, bradycardia, constricted pupils, more saliva, and more bladder contraction. I'm going to write that for a second. And then the lungs, the bronchi relax. So who are we worried about? What's our caution?
Wouldn't you be worried with someone who has heart arrhythmias or be concerned with electrolyte imbalance if their GI is overactive?
Potentially, yeah. So if someone gets diarrhea, you always have to worry, depending on what the volume of diarrhea is. They could end up dehydrated or have electrolyte imbalance. If someone has slower heart dysrhythmias or already a low heart rate, then we would have to worry. Um, Anything else? And this means the bronchial muscles relax. So that, um, I'm sorry, they can't relax because remember this is the opposite of the sympathetic response. So for these people, for this category of medications, we have to be sure this is the asthmatic, so we need to caution with them. And what do you guys think about the bladder contraction and increased GI motility? There is a caution with that too. Do you remember? I mean, we just talked about it, so sometimes it's hard to remember.
Sorry, what was the first part of that question? I only caught the tail end.
Well, it's okay. So, if you're taking an anti-adrenergic medication, um, so you're blocking the sympathetic response closer to the parasympathetic response, then you have to worry potentially there's going to be an increased bladder contraction, increased GI motility. What kinds of patients, besides worrying about diarrhea and electrolyte disturbance and dehydration, what kind of patients shouldn't be given something that'll increase bladder contraction or increase GI motility?
Someone who's got an autoimmune disease, maybe like celiacs, if they already have GI troubles absorbing.
That's good. So if they already have a lot of increased motility, then that would be bad for them. Um, or if they have an obstruction. Because if there's something that's already blocking that area and we just increase contraction against the blockage, then that just makes the patient, that gives them a lot of pain. If I have a tumor or something inside my intestine that's blocking the intestine and I give somebody something that makes the intestine contract a lot, then it causes pain and cramping. If the person has, again, that benign prostatic hypertrophy, and we increase contraction of the bladder against the blockage, that hurts. So we have to worry about that too. The thing that I also want you to see is that cholinergic is similar to anticholinergic. Sorry, cholinergic is similar to antiadrenergic, and adrenergic will be similar to anticholinergic. They are similar responses. So antiadrenergic is closer to the parasympathetic nervous response. Activating a cholinergic receptor is acting like the parasympathetic nervous system. So these two, that cholinergic and anticholinergic, are closer together in terms of these things that we have to worry about that we just talked about: vasodilation, can't relax the bronchioles as well, bradycardia, low blood pressure, pupils constricted. Those same things could happen with cholinergic medications. And the one that we talked about that affects the parasympathetic nervous system was bethanechol. Um, and so these same concerns are also true. The one that we talked about for myasthenia gravis is supposed to just work on cholinergic receptors on the muscle, but it's possible that we would have to worry about these same issues as well. The anticholinergic medication we talked about was atropine, and that's blocking cholinergic receptors. So it'll be closer to the sympathetic nervous response, even though we're blocking the parasympathetic response. We're not really acting on adrenergic receptors. The response will be similar to the adrenergic issue or adrenergic medications. So we can look at the, I'm going to post it on Blackboard, but you guys you could just, I'll put a blank one on there just with the, fill in the blanks, and I'll put one that's filled in, so you could try to challenge yourself to see if you can remember it, because that will be, a lot of test questions that could potentially show up. So you can sort of test yourself too. So that medication that we talked about that was anticholinergic, so closer to the adrenergic response, but we're blocking the cholinergic receptor, will be similar here with the decreased GI motility, vasoconstriction, tachycardia. That's why we gave it, usually. Dilated pupils, decreased saliva, decreased bladder contraction. That's what we'll see on the anticholinergic side. And because it's also blocking cholinergic receptors potentially at the skeletal muscle, the addition that we have here, which is always on the test, is that you can't give anticholinergics to people with myasthenia gravis, but you can give medications that are adrenergic to people with myasthenia gravis. So this can sometimes be difficult to understand. It's because cholinergic receptors are on the parasympathetic nervous system and the skeletal muscle. Adrenergic receptors are on the sympathetic nervous system, but they don't have any activity on muscles at all. So if I give someone an anti-adrenergic medication or an adrenergic medication, I'm not affecting any skeletal muscle at all, because there's no crossover to the skeletal muscle. But if I do something that's meant to be the autonomic nervous system, the parasympathetic nervous system, if it's cholinergic or anticholinergic, I have the potential to bother other cholinergic receptors, which happen to be on skeletal muscle. And so I have to be careful in terms of myasthenia gravis, because that condition causes the person to have weaker muscles to begin with. So anyone with myasthenia gravis, unless they're overdosing on a cholinergic medicine, they should not be given an anticholinergic because they have a potential for a problem. So I will put a variation of this that's blank and a variation of this filled in onto our Blackboard site so that you can practice. Excuse me. And then we will get into the last part of this lecture, which is the muscles themselves. So instead of manipulating the actual neurotransmitter, we can try to do that. We talked about trying to augment muscle movement. Now we're going to talk about relaxing muscle movement. So we talked about this. Oh, this is a much better picture than what I drew, but we did talk about this before the break, where there's a nerve and a synapse space between the nerve and the skeletal muscle. There's vesicles that have acetylcholine in them. If the nerve is stimulated, acetylcholine comes out into the synapse and interacts with receptors on the muscle. And when it does, that causes calcium to go into the muscle for contraction. And then when it's time to relax, the cholinesterase enzyme goes inside the synapse and gets rid of the extra acetylcholine so that the muscle can relax. So if we want to relax the muscle, we could try to stop stimulation of the muscle, or we can try to block those receptors on the muscle, or we can try to not allow calcium into the muscle for contraction. We have several options to try to decrease contraction or relax the muscle. And there are two different types of muscle relaxers that are involved. So it's muscle spasms are involuntary contraction of muscles, and that causes pain or impairment of the joint. And people can have muscle spasms for different reasons. Some people have muscle spasms because of nerve complaints like nerve disorders like multiple sclerosis, and they will constantly send messages down to their muscles and get contraction and spasming of their muscles that can be quite painful. Or you could have a temporary injury. So say you fell and you knocked part of your backbones out of alignment, or you knocked a joint out of alignment. Your body's protection of you after you damage a joint is for the muscles to contract to protect the joint. But that is painful. So you can take medication to try to relax the muscles at that time. And so the two options are centrally acting and peripherally acting medications. And our prototypes are baclofen, which is similar to cyclobenzaprine, which is Flexeril, and Dantrolene. So if you're going to use, or if the person is going to get baclofen, what you're doing is actually changing this part. If you give a medication like baclofen, you are stopping, this is sometimes called centrally acting, you are stopping the activity of the nerve, you are stopping the activity of this nerve that was supposed to allow for acetylcholine to go into the synapse and then cause contraction. You're blocking that lower nerve's activity, so then the muscle can relax. So it decreases hyperspastic reflexes, but it can be sedating, because any medication that is working more in the central nervous system has the possibility to be sedating. So we have to be careful about that. And it can make people dizzy or feel weak or tired. And so because it's sedating and the person can feel sleepy, dizzy, weak, we have to worry about the elderly in particular, because we don't want them to fall and get injured. And so there's always caution with the elderly. And there's certainly caution with other medications that are sedatives. So what other medications have we talked about that are sedating?
The opioids.
Yep, the opioids. Those pain medications definitely are sedating. We talked about one blood pressure medication that was sedating because it worked in the brain.
Was it clonidine?
Yep. Scott is on today. Yes, clonidine is that, and then of course other things that you might take that you shouldn't, like alcohol and things like that, or any of these other muscle relaxers together. And then we have issues with nausea, vomiting, constipation, and urinary retention, because you're kind of relaxing a lot of nerves. So kind of slowing the GI and GU tract down a little bit. But it does decrease those muscle spasms. Baclofen can be given by different routes. So it could be given intrathecal, which means you could actually give it directly into the epidural space through an epidural pump. and is sometimes given to people who have chronic spasms as a way to decrease their pain. You cannot just abruptly withdraw the intrathecal pump, or anyone who's on a chronic baclofen treatment, if they take it often, you can't just stop it, or they will go through withdrawals that include possibility of anxiety, hallucinations, and seizures. And so this idea of withdrawal can often be confused with addiction. It doesn't mean that they're addicted to the medication, it means that they are physically used to the medicine. So their body has changed the amount of receptors that are available. Their body has changed because they're always getting that medicine. And if you take it away, the body doesn't have any time to adjust. And so they will become extremely anxious, restless, hallucinations, and seizures, which is different than taking the medication not because of muscle spasms, but because they like how it feels. That would be an addiction. So you always have to taper off the medication over 1 to 2 weeks, or the person can get really sick. And our last medication, this went a little bit faster than I intended, but I'm sorry about that because I like to use all your minutes. The last medication is Dantrolene, which is a direct acting, peripherally acting muscle relaxer. So whereas things like cyclobenzaprine, which is Flexeril, or baclofen work by stopping this nerve from even getting the message to release that neurotransmitter, baclofen works here. I'm sorry, Dantrolene works here. It does not allow the calcium to go into the cell to allow for contraction. So even though the message might have been received and the acetylcholine was released into the synapse and there was interaction with those receptors, if we don't allow the calcium to actually go into the muscle itself for contraction, then the muscle doesn't contract. And so it is a very good peripherally acting medication. It can be given by mouth or IV. If it's given IV, it is a medication that's used as an emergency treatment for a condition called malignant hyperthermia. Malignant hyperthermia is a chemical reaction to some anesthetic agents, is one of the reasons it occurs, which causes immediate and constant muscle contraction. And because all the muscles are contracting, the body temperature increases significantly. So the patient can actually have a temperature of like 105, 106, and that the temperature is so high that it can actually cause permanent brain damage. So it's not very common for it to happen. It does tend to be brought on by, like I said, anesthetic agents, and it is a genetic issue in how the person metabolizes some of the induction agents for anesthesia. So that's one of the reasons why if you go to the hospital or anything, they always ask, is there a history of reaction to anesthetic agents? Because then you immediately have to give IV Dantrolene, which will then quickly will stop calcium from entering the muscle so the muscles can relax and the temperature can go down. So I've only taken care of one patient who developed malignant hypertension in the operating room in my nursing career, and I've been a nurse for a long time, so it's not very common, but it can occur. Other issues that happen when taking Dantrolene, because it is a powerful muscle relaxer, again, it's another weak, drowsy, dizzy. So we have to worry about people who are elderly. We have to worry about people who are on multiple sedative medications. And then in this particular medication, because it uses the liver to metabolize, if the patient's liver doesn't work, they're more likely to have toxicity, meaning there's too much, too weak, too dizzy, very tired, or the medication can cause hepatotoxicity. So how would we know if the patient had hepatotoxicity? What's the blood test we would check? Oop, we lost
Repeat that again.
What blood tests do we check for hepatotoxicity? AST, so it's the liver function tests. So AST is one of them. ALT and bilirubin. So what kind of symptoms will we have?
The jaundice, you're going to have the pale excretions, bilirubin in the urine.
Right. Exactly. So that's the end, but now I'm gonna see who's all here before we leave. So I can see, right, so if someone has liver disorder, just to say that before, if someone has a liver disorder, they have ascites, abdominal pain, maybe a decreased appetite, yellowing skin, the things that you guys were talking about. So we are done, but I'm going to just be sure that we left with the same people here. So I see that. I'm writing it down. So, Ryan, did KO bail on you, or is he still with you?
Hey, Kale, say hi.
Hi.
Thanks, guys. Nicole.
I'm here. Shay's here, but it's for some reason not letting me type in the box.
Okay. Well, I'm glad to hear your voices. You guys are allowed to talk. For real. Keisha. I know. It's annoying. 1, 2, 3, 4, 5, 6, 7, 8. Emily, 9, Justina, 10, Stephanie. Okay. I just don't want to suffer alone. I want you all to suffer with me. So, next class, we'll have our quiz, and suffering together is best. I'll put up that sheet that we kind of did during class. And I actually have some YouTube videos with this information too, because last year this is when we had to move everything to online, so you can see those too. I have a YouTube station that's kind of old, but anyway, you guys have a good week. I will talk to you next week.
I have a question.
Oh yeah.
What doesn't have to do with everybody else, but what I emailed you about earlier with the exam, was that included in my grade or?
Yes.
Okay.
That was taken care of.
Oh, okay. All right. That was all I was curious about. And then can we set up a time to go over the answers with you on a separate?
Yeah, I will send me an email so that we can come up with a time together.
Okay. Sounds good. All right.
And
have a good one.
Sure. Thanks, you too. That's the same for everyone. If you want to set up a time in order to go over the exam, then just email me and we can make an appointment.